So you talked about the digitizing of the records and how expensive that's going to be. Can you talk a little bit about how that, one of the things we try to do at Forefront is always tie it back to me, really, and how will that expense eventually benefit all of us? I assume there's some savings, but is that quantifiable?
I think you've hit on a really sort of, it's important but kind of almost controversial question. I think that's really where you get the resistance to digitizing, is because people say, can you really show me what this is going to save over time? And it's hard because there is such a significant upfront investment. The concept is that over time, if you have more connectivity of information, you have better means of making decisions and providing care. That's a theory, right? We've seen it put in practice where, for example, where we've been able to analyze it, we've digitized information, been able to analyze it and create interventions that we know avoid costs. They don't necessarily save costs, but they avoid costs. So, and that's difficult to quantify because what you're trying to do, to use that we have so many buzzwords in healthcare, phrases now, it's bend the cost curve. Who came up with that one? I don't know, but it's out there now. So the idea is that instead of the curve going this way, we're starting to at least stabilize or have the cost of healthcare grow in a reasonable manner related to our, our national economy. It's not overtaking. So the whole concept behind electronic health records and health information exchanges is putting what is a very disparate care system together in a virtual way. I mean, has anybody had a complex condition where they had to go to multiple specialists and then they had to go to the hospital and they had to go here and there, or multiple procedures? I mean, you're like carrying this book around with your stuff, and you get to the doctor, you don't have the right piece of paper or the right film or whatever it is. And when you get into areas like oncology, and people, I mean, I could go on for hours about the lack of coordinated care in oncology. You're just, first your primary care doctor says you have, if you're a woman, you have a lump, go have the radiology, and the radiologist says, oh, you have a lump, you need to come out. And then so you go to the surgeon, and he gets the film, and then he's basically, you're starting all over every time you go to one of these places. You're providing the same information over and over. They're not really talking to each other. The radiologist does send the film to the surgeon does the procedure, and then sends you over to the oncologist, and then the oncologist determines your treatment, and they may have to consult with 5 other doctors, so they send you to those 5, and then you're supposed to collect the reports. And I mean, it goes on and on and on. We treat the body, we treat our humans like we can take them apart and send them to different places, and they're like it's all going to come back. So back together in some coherent fashion. The idea of electronic records is you're facilitating the exchange of information around all these different settings of healthcare, and that's going to make it more efficient. That only occurs when people use the systems, they use them efficiently, they actually access the knowledge that's available to them or the information that's available to them. I mean, I hear things like, well, I don't know if I want to know everything, because then that means I should have, maybe I missed something, or I have to take responsibility for knowing that. And if I don't know it, then I can just hand it off to someone else. So this is unfortunately the nature of how healthcare is delivered in this community. We call it a healthcare system. It is not a system. It's just healthcare, and you just bounce your way around it, and you struggle to get it paid for. And so I think you can come up with discrete examples of how electronic health records are intervention programs where we said asthma, gosh, if we can intervene, use information to intervene. The technology's really not doing it for us. The technology's providing the information that allows us to then intervene. Now, it might also allow us to track better, design interventions, make sure that they're happening, and feed that information back to see the patient getting the care that they need. So that is facilitative. But it's actually the care that's provided that is changing. The path you would have taken to treat a patient might change by virtue of having this information. That's the hard part.
Yeah. Are there systems that are doing it well? Are there
states
or healthcare districts?
I think
probably your best examples are what are referred to as integrated systems. We're talking the Mayo Clinics of the world, the Kaiser systems. They're what we call closed models. Doctors, hospitals, all multi-specialty, all in one group, all connected by electronic health records.
So
They're cohesive. You know, you don't, if you go from one specialist to another, you're going to that within a same practice. That's the beauty of MD Anderson. That's why people love to go to MD Anderson for their oncology care, because everybody's there. They look at you like you're like the universe, and they'll kind of, you know, rotate around you, figuring out what you need. Where if you don't go to MD Anderson, you're just going to every single, that care is divided up and spread out over multiple places, and you have to take yourself from place to place to get what you need. So that's why people feel so cared for at MD Anderson, because you're coming in and they're all kind of circling around you, and they're consulting each other, and they're making adjustments as they go, and they're sharing information real time, and you're not getting bounced around from place to place trying to, you know, transport what you think you need. And so those models are most effective. If you look at the Mayo Clinic, if you look at the system itself and who it serves and how it's grown over time, they have managed to keep the number of hospital beds required to treat their patients at a minimum, have the right levels of care so that they're reducing the acuity of the patient, so you have less need for hospital beds. People end up in the hospital usually because something's gone really awry, you know, forego surgical intervention or whatever, or something, I guess, elective, like dermatology. I mean, if you're going to have a facelift, you're going to have a facelift, right? But, you know, someone who's going into the hospital because they're seriously ill usually results from an illness that hasn't been caught somewhere along the way. Well, the whole Mayo system is designed to, with the right ratio of doctors, types of doctors to treat patients, and they've managed to keep the investments in hospital, which is the highest cost level of care, to a minimum. And because they're doing the right care and keeping people well. That's the whole premise of the healthcare system, is if you move people to wellness and prevention and keep them well, keep their chronic diseases managed, you will have that return. So again, programs support the delivery of care, but if we don't transform the delivery of care, it's really not going to make much difference. We're just putting, which is the criticism of implementing all these electronic health records. You can implement them and they're very costly, but if you don't use them to change how we deliver care, how do you show the return? I don't think we have a choice, though. We have to do it. We have to do it on the theory that it's going to work and continue to improve it.
Well, I want to thank everybody for being here. I want to give a special thanks for our panelists, Patricia Young Brown and Terry Brown, and encourage you all, and thank very much for Applied Materials for hosting us today. Encourage everybody to go to Forefront Austin, read the technology issue, read the articles that we've written. Stay tuned for our energy and environment issue, which will be coming out in April. We'll be talking about what is the biggest environmental challenge Austin needs to face in the next decade. Very important stuff. And back to Tricia's comment about the 80-20, and we are very much, Forefront's very much the 80%. We want to have the deep conversations. There's lots of attention out there in the media for a lot of the big stuff, the popular stuff. We're the conversations, and we encourage you to go join in the conversation and the dialogue with us. Thank you.